Hello and welcome everybody to week 3, module 3 of the IT and Health Informatics webinar short course, co-presented by IT Masters and the ECA College of Health Sciences. And when I say co-presented, I mean that actually College of Health Sciences are presenting it and IT Masters are hosting the infrastructure basically. So as everybody comes in, I would ask you, as always, to remember to say hello in the chat. Tell us where you're from. Tell us if you're having a good day or not, what the weather's like where you are, and all of that sort of stuff. As we've said before, this is our first co-presentation of a short course between the two of us, and we're really excited about it. It's been a really good set of sessions so far. A bit of sort of health stuff while everybody's coming in, as in housekeeping. Remember to send your messages to everyone and not just hosts and panelists. We expect and hope that you will give us your questions in the Q&A that's at the bottom of the screen, not just in the chat, because the chat does rev past from time to time at a fairly good rate. And really the chat is for you guys to chat amongst yourselves and just keep everything going. I'm really happy tonight that John is our primary moderator for the chat session. So welcome to John. This is his second session doing this, so we're really happy to have him along. And of course, Kit is also here this evening as well, riding shotgun, as it were. Before I welcome our lecturers this evening, I've got two other announcements to remember, and good evening. And as always, I will say hello to a few people in the chat because I can see people from the Netherlands, from Sydney, from Wurundjeri country in Melbourne, Nigeria, and all over the place. But yes, I have two things to just give you a bit of an update and a reminder on. The first is in week 3, we send out a survey, and it'd be really great if you could spend some time filling in the survey and telling us what you think of the course. It's got only about 4 or 5 questions from memory, and it's great to get that feedback because it does help us when we're designing new courses and how we feel about the courses, etc. So please get into the survey. You see that John has just bunged it into the chat. So click on the link and fill it out as you go. The second is I alluded last week to a webinar on AI and healthcare. That is going to be on the 21st of May at around about this time, 7 o'clock. We will be sending out the invitations and all of the sign up pages for that tomorrow or Monday. So please be on the lookout for that. If you haven't seen it in those couple of days, feel free to send us a note, have a look at the websites of either IT Masters or CHS. You might be able to find it on either, and just let us know that you're interested and we will send you the link to sign up for that. We're really excited about that too. Dr. Muhammad is going to present on that because he is actually an AI guru. He's written multiple papers on AI in healthcare, and I've had a bit of a preview of some of the stuff and it looks fantastic. There'll be lots of chat. Having said all of that, I think we've gone through all of the housekeeping stuff, and I think it's time to get going early tonight. Welcome, and how are you, Dr. Muhammad Khalifa?
I'm good, thank you very much, Shane. It's my pleasure to be here with you today.
I'm sure it is.
And Fazu, you can start if you would like to start the first
Yeah,
topic.
yeah, sure. Thank you, Mohammed.
Thank you.
Welcome to Module 3. In this module, we will explore more examples of health informatics. If you were joined in Module 1 and Module 2, just would like to recall a bit of knowledge from there, what we did in Module 1. In Module 1, we introduced the basic concepts of health informatics. And in Module 2, we were focusing primarily on electronic health record. Now we will broaden our understanding in this module by examining additional topics such as mobile health, telehealth, and how they contribute to modern health systems. Like every week, we have 4 topics to cover this week as well. Topic 1 helps us understand health informatics from a broader perspective as it is the engaged e-patient. Topic 2 and 3 will focus on personal health record and telehealth. In topic 2, we will be focusing on mobile health. So let's start with our first topic, that is engaged e-patient, the engaged e-patient. Let's first understand before we look at e-patient or engaged e-patient, let's first understand what is connected health. Connected health is a system that connects different levels of cares, such as primary care, specialist, hospital, and home care, which help to provide coordinated and continuous services to the patient. Integrated healthcare isn't about merging organizations or sharing ownership. It is about creating networks and communication between different providers to serve patients more effectively. For example, if a patient with diabetes is going to see a general practitioner, they may also see a specialist, a dietitian, and receive home visit from a nurse. So, an integrated health system, all these providers share information and work together to manage the patient condition smoothly and efficiently, even if they belong to different organizations. The same patient may use a mobile app to track blood sugar or read patient form for tips or share their experiences through social media such as Facebook, which means the patient is becoming empowered. In such an integrated system, it's not just healthcare providers who are connected, as I mentioned earlier. Patients themselves are becoming active participants in managing their health. This brings us to the concept of e-patient. Moving further, e-patient, you might quickly assume that e-patient means electronic patient. While that's partially true, it doesn't fully capturing the meaning of the term e-patient. It doesn't just mean electronic, but E in an e-patient can represent multiple empowering qualities such as equipped patient, enabled, empowered, and engaged. Moving further, looking at the e-patient of 21st century. The e-patient of 21st century is net empowered. E-patient is the patient who actively use the internet and digital tool to manage their health. So we can say e-patient envisioned a future where patients take a leading role in managing their health. Healthcare professionals' role shift here and they are becoming coaches, supporter, as well as coordinator, helping patient with their self-managed care. Moving further, this is also talking about e-patient. So we can say today's e-patient actively participating in their own medical care, primarily by using internet and other digital tools to gather information about medical conditions that affect them and their families. Looking at this concept bit more and understanding the full meaning of e-patient, we can say e-patient can represent multiple empowering qualities of modern healthcare consumers. These qualities are enabled, equipped, electronic, empowered, engaged, and equal. Enabled mean a patient have the means and abilities to involve in their healthcare decision. They are equipped with tools such as mobile devices, have internet access, etc. Electronic mean they use digital tools and internet in their healthcare management. Empowered where they feel with the help of all these coordination care and tools they feel confident due to the information they gather from various resources. So they are actively participating in their healthcare. This means they are actively engaged in their healthcare in their health management. They view themselves as a partner with their doctor while they have to make decisions for their own health. Moving further, how can e-patient help heal healthcare? Today's e-patients are transforming healthcare in powerful and unexpected ways. They are no longer passive recipients of care. These individuals are proactive, they are informed and digitally connected with each other. So they begin by acting as hunters and gatherers of medical information, oftenly search in the internet for the latest treatment, for example, for clinical trials and for research if they have research about the medical condition they have got. So they will be gathering all the information if they have some health issues. Second point says content, connectivity, and community where. So e-patient don't just consume information, searching the information and consuming it. They also build connections. They use digital platform to access reliable content from relationship with other going through similar kind of health conditions or similar kind of experiences, and then participate in supportive online communities. They are also central to what we call patient-centered network. In these care environment, e-patient collaborate closely with doctors, with caregiver and fellow patient to ensure that healthcare decisions are tailored to their personal needs and their circumstances. In complex or rare medical cases, e-patients often find support and guidance in dedicated online communities. These complex e-communities become lifeline for people who might otherwise feel isolated, offering empathy, shared knowledge, and hope. So ultimately, e-patients are not just participating, they are reshaping healthcare by challenging old norms, questioning assumptions, and sharing what they learn. They are shifting the flow of medical knowledge from one way street to another collaborative exchange. Moving further and understanding this concept bit more, as e-patient continue to reshape the healthcare by becoming more informed, connected, proactive, their journey is increasingly supported by digital tools. They use them almost every day. For example, Google Assistants can support e-patient by enhancing their ability to access, manage, and act on healthcare information. E-patient can ask Google Assistant some question, for example, what are the symptoms of a certain disease, let's say diabetes, what is a health blood pressure range. This helps them to gather some information about the disease or the condition they are going through. In we have more tools here, such as Facebook. E-patient can join condition-specific groups there, can share the experiences, learn from treatment. In Instagram as well, e-patient can share their journey. They can document their health experiences, treatment challenges, milestones, photos, videos, etc. As we have seen, today's e-patient are empowered by everyday digital assistants and platform like Google Assistants, Instagram, Apple Health, etc. These tools make health information and peer support more accessible than ever before. Moving further, if we talk a bit more about connected world or connected healthcare, the key takeaway from this slide, I would say that we can say the growth of mobile technology and internet access has opened the door to something even more transformative, connected, data-driven, and intelligent healthcare system. Moving further, looking at our connected world, so we can say this explosive growth, as you can see, the data is a bit old, but still it indicate us that explosive growth in internet usage, mobile connection, and data consumption has impacted our healthcare ecosystem. And next, please. So if we talk about healthcare ecosystem is the large ecosystem where we have providers, we have payer, we have supplier and regulator. As we can see, today's healthcare ecosystem is dynamic network of provider, payer, supplier, and regulator, all increasingly interconnected through digital tools and data. But to truly meet the need of patient in this complex environment, we must also rethink how care is delivered. That is where the principle of modern patient-centered care come in. Moving further and looking at the principle of modern how can healthcare be redesigned, I would say these are some of the modern principle of redesigning healthcare. We have continuous healing relationship, personalized care, open information flow, evidence-based decisions, system-wide safety, transparency. These principles of modern care are not just idle, they are increasingly being enabled and accelerated by technological and societal change. Moving further and understanding what's driving the change. So we have already seen Facebook, Instagram, those digital tools are the driving change behind it. We also have innovation like Health 3.0, which is a kind of more interactive based on the insightful decision which are coming through the patient data. So these modern tools, internet, mobile devices, mobile applications, wearables, these are all, these digital tools, all powerful digital tools are driving the change in this area. Moving further, please. Talking about the health e-people, the online consumer experience, we can say for example, well, individual are typically using the internet casually, searching for information. For example, I'm quite fine, so if I have to search for the information just because I want to be aware about my health, or it could be somebody newly diagnosed individual. Newly diagnosed patients often find themselves overwhelmed with the feelings, so they dive into the online search to better understand their condition, explore treatment option, and assess the information what next step they should take. For those with chronically ill and their caregiver, the internet become a vital ongoing resource. These individuals rely on online tools. They can communicate with the community and can stay up to date with health information. Moving further, looking at the next slide, please. The health system is now undergoing in a significant transformation with a strong focus on the convergence of e-patient, clinician, patient-centered model of care and informatics system to converge and align accordingly. So in this evolving landscape, Warwick offered three useful maxims that perfectly fit here. These principles emphasize that the needs of the patient always come first. that no decision would be made without the active involvement of the patient, nothing about me without me, and that every patient is treated as unique and individual. So, patient centered has now become a key dimension of healthcare quality, standing on its own merits. Moving further, looking at the concept of Health 3.0, as I mentioned earlier, Health 3.0 is the concept where data is playing the key. Data is the key component there. So Health 3.0 is actually the application of Web 3.0. Web 3.0 is where we say more interactive website. In Health 3.0, we say that we are making more informed decision, we are making more personalized decision based on the data which is already available. So just wrapping this topic with my next slide, that is P for medicine. Um, in this model, as we have internet, mobile technologies, we have access for the internet, this new model, before medicine model, has evolved. So physician will have access to as well as a healthcare professional, and the patient will have access to personalized actionable information that will enable them to make more cost-effective diagnosis and treatment within clinics, hospitals. Meanwhile, both patient and consumers will be empowered to use personalized data in their home and workplaces to maintain healthier lifestyle. That is where I would say I will pause the topic and will hand over to Dr. Muhammad Khalifa to take you through topic 2 and 3. Thank you.
Thank you very much, Vasu. This is a very interesting topic 1. And now we move to topic 2, which is about personal health records. So the personal health record is a version of the electronic health record. We can call it electronic personal health record because it's becoming more and more private and secure application through which the individual patient can access and manage and share his or her health information with others. Just like, for example, my health record here in Australia as a project where the individuals, we can manage our own health records. We can get the reports, we can see the lab results, we can see radiology images and reports and so on. And then we can allow other users like other doctors, other hospitals to access this information when we need to. When we are visiting a different general practitioner, a different GP, or a different medical center, or a different hospital, and so on. So we are now moving from the concept of electronic health record into the concept of electronic personal health record. So this personal health record, you can find that it is provided with information coming from different sources, such as wearable devices, mobile apps, smartphone mobile apps, different sensors, different personally added information, preferences and settings. And then the information is exchanged with different healthcare providers, with different exams and image centers like radiology centers, laboratory centers, health insurance, and government, and so on. So the connectivity is getting wider and richer with the types of information shared among all of these parties. Now, what's driven the move towards the personal health record? We have a rise of personal computing devices. For example, any smartphone now is almost equivalent or sometimes even more advanced in processing powers compared to personal computers just 10 years ago or even less. Today's iPhones or Samsung or other devices, they can process information, they can process images, they can get connected to the internet very fast, they can get rich data, video streaming, and different things that can really help the end user or patients or health consumers to get connected, not like mobile phones 15 or 20 years ago. We didn't have the smartphone activities and functions. So the main principles for an ideal personal health record is to be very comprehensive, including longitudinal data storage, which means through time, from birth, for example, until death, or from the beginning of the first interaction or encounter with healthcare professionals until data is managed with different providers. The concept of data ownership, control, and privacy in the hands of patients and health consumers, the portability of the data and the images, and the ability to transfer and exchange different types of data and images and rich media with other parties, with different parties, the accessibility, the unique and desired services determined by the health consumers and patients, and also customization levels. So all of that were the principles behind the development of ideal personal health records. Now, when we look at these personal health records, we can see that they can be standalone personal health records where GPs and other providers or hospitals or medical centers need to access these systems separately, or they can be connected with the electronic health record that is hosted in hospitals and other healthcare organizations. So these are the main two types of personal health records. When we look at the meaningful use of a personal health record, we will find it including different types of media, different types of information, monitoring of chronic conditions like diabetes, hypertension, cardiovascular conditions, including receiving also prescriptions, receiving alerts and messages from lab results, radiology reports, images, appointments, and so on. So this is part of the meaningful use of personal health records. Now, do we have evidence that these personal health records have benefits? Yes, because they can improve patients' engagement based on research and existing evidence. They can help coordinate and combine information from multiple sources. They can ensure patients' information is available at any time, anywhere, with more portability and accessibility. They can also reduce administrative costs, reducing the need for asking the questions, the same questions, identifying the patient again, retrieving the basic information, the basic diagnosis, allergies, conditions, and so on. They can also enhance the provider to patient, like doctor to patient or nurse to patient communication, and can also encourage family health management as well. However, we still have barriers and challenges to the adoption of personal health records, such as the lack of widespread awareness among health consumers about the importance of these personal health records. Sometimes the poor usability of personal health records because they are not easy to use, they are not user-friendly, they need a lot of customization, or they might need training for these health consumers and patients, or their functions could be complex for older generations. We still have privacy concerns by many people, including end users and healthcare professionals. We still have the problem of digital divide between those who have and those who do not have the technology. For example, if we are talking about smartphone apps, if some people or a subpopulation living in poor areas where internet is slow, or a poor country where they don't have access to these smartphone apps or smartphones, this could represent an increase in the size of the gap between those who have the technology and those who don't have the technology. So the technology is not always providing equity and equality for everyone, because sometimes it's becoming expensive, not just for the end users, but also for the government and countries to build connectivity, to build infrastructure, internet speed, and so on. Provider engagement is another barrier because we need to encourage them to participate, and we still have issues about interoperability, where personal health record data and functions sometimes are constrained because of different software packages and coming from different vendors and companies. Here in Australia, My Health Record is a very famous example for a personal health record where all reports and data and lab results and radiology findings and so on, they can be found on My Health Record for each patient and health consumer. And then we can allow these data with different sources to be shared among different healthcare professionals and hospitals as well. Now, My Health Record, as we know, includes health summaries, as we mentioned, medications, prescriptions, lab results, discharge summaries, letters, referrals, and so on. It could also include advanced care planning information or information about the patient's past health events, previous operations, previous admissions, pathology reports, diagnostic images, children development information, consumer-centered information, or even consumer-entered information personally entered into the system, Medicare overview, and so on. Now, will we have a My Health Record or not based on the Australian regulations? You can join or you can quit to have My Health Record, allowing or banning other users from accessing your My Health Record as well. Now we can move to the next topic, which is about telehealth applications for delivering care at a distance. And then the last topic will be presented by Dr. Vaso Sood. Telehealth and tele applications, as we know that connected health is driving the integration between different healthcare services and different healthcare settings. So we will find that connected health is an approach to healthcare delivery that leverage the systematic application of healthcare information technology to facilitate the access and sharing of information. And then when we look at the connected health, as just Vaso mentioned, we have an ecosystem for this healthcare system, including hospitals, pharmacies, medical centers, health insurance, diagnostic services, primary care, secondary care, tertiary care, and so on. So we call that an ecosystem. And then the journey to the connected health includes different stages from the adoption of IT until the connection, until achieving clinical effectiveness and efficiency, which we can call together clinical efficacy, which means that we can achieve the objectives of the healthcare provision and at the same time optimize the utilization of resources. So effectiveness is more about achieving the objectives, and efficiency is more about optimizing the utilization of resources. Now, the dynamics of successful connected health, we can look at 6 key themes characterizing those organizations successfully progressing onto the journey of connected health. We will notice that they need a clear vision and clear leadership model focusing on improved health outcomes, and then strategic change management, which should be always organization-wide. We need robust technology that is reliable through infrastructure, which can ensure the delivery of healthcare services. We need co-evolution, which is the balance between the top-down and bottom-up implementation of these systems. So top-down means implementation of planned software packages, updates, and so on. Bottom-up means supporting the implementation of these systems through good feedback from end users, training of end users, providing end users with the sufficient resources and skills and knowledge required to optimize the use of these systems. Now, change management and clinical change management is also important for these connected organizations, as well as integration of systems that could drive this type of interaction. When we look at the connected health through different countries, this is just a sample of comparison, comparing Australia, Canada, England, France, Germany, Singapore, Spain, and the US. We will find that some of them have very good sustained excellence. Some of them have strong performance, and some still have needs and initial steps to be done through different vision and leadership levels, strategic change management, robust technology infrastructure, co-evolution, clinical change management, and integration. So each country has its own status, or they are at their own stage of implementing this type of connected health. And from that matrix, based on studies reported by these different countries, we can notice that some of them have achieved better than the others in specific dimensions of these 6 dimensions. And then when we look at the 3 levels of value creation, we will find that we usually begin by the level of clinical efficacy, effectiveness, and efficiency. And then we can share the knowledge and share the success. And then we can achieve some sort of care transformation through digital applications and exchange of information from one system to the other. This is why we always have value to use the data exchange and information exchange platforms. In the United States, it's the HIPAA, for example. Here in Australia, we have our own framework and so on. So when we look at the connected health dynamics, we will find that the vision and leadership is very important. We need strategic change management, as we mentioned, robust technology, co-evolution, and clinical change management as well. So this can achieve more and more successful integration and interaction that can drive the evolution of these systems together. Now, the 6 dynamics of connected health, as we mentioned already this slide. In the Australian context, to date, connected health progress in Australia has varied across different care settings, sometimes geographic regions, because we have rural areas and very remote areas. We have major cities. We have almost like 6 or 7 levels of classifications of how central or peripheral or far remote areas we are, because Australia is a big country in terms of geography. It's the largest island worldwide and the smallest continent, as we know. Now, this radar graph shows, for example, primary care, how primary care is maturing into different functions, like, for example, organizing electronic tools to reduce administrative burdens and electronically entering patient notes either during or after consultations. We will find that these 2 or 3 are being more and more implemented successfully, while we still have electronic notification of patient interactions with other healthcare organizations still like 20%, not like 80 or 90% mature and functional. So this radar graph shows us the let's call it the situation or the status of digital transformation in the area of primary healthcare, comparing these indicators or functions together. We can compare the same radar graph or figure comparing primary care to secondary care. We will find that primary care is even more advanced than secondary care in the same functions. So secondary care is almost like 50% at the best, which means, because secondary care is mainly hospitals, while primary care is mainly GPs and medical centers, which have more flexibility because they are smaller organizations and they can adopt technology faster and more effectively. Now, telehealth, the case study of the connected delivery at distance. What do we mean by telehealth? It includes all types of functions, starting from providing healthcare professionals with vital signs, with steps, with heart rate. Nowadays, simple ECG can be done electrocardiography, or the heart electrical activity as we know it. ECG stands for electrocardiography. So these ECG can be sent to the health professionals, to the doctors, through wearable devices, smartwatches. Most of iPhones and smartphone apps and smartphones have counting steps, apps for sleeping patterns. You could have apps for nutrition, apps for calorie control. We even have AI-based applications that can evaluate and estimate the amount of calories in a dish. If you took a picture of that dish, if you took a picture of the food that you are going to eat, it can give you an estimate number of how many calories are included in that meal. Booking appointments, monitoring other vital signs, monitoring blood pressure, monitoring blood glucose levels through devices that are integrating to smartphone apps, and then from the smartphone apps, the signals and information and data are sent to the hospitals and so on. So this is one of the concepts behind telehealth. Now, telehealth generally is defined as the use of technology-based virtual platform to deliver various aspects of health information, prevention, monitoring, and medical care. It's one of the fastest growing areas in healthcare, in digital health, because nowadays we have more and more technologies with less costs. We find that teleconsultations can be done easily. So you can do Zoom session with your GP or Teams meeting with your doctor. You can send them the report. You can send them, even the images themselves can be sent to the doctor or to the medical center or to the hospital through electronic means, applications, emails, every kind of technology that can connect patients to their doctors is considered part of the telehealth and telemedicine. Now, is telehealth new? Actually not, because the idea started very early, and maybe 100 years ago, the concept was that doctors can ask questions and can diagnose patients over the phone, over the radio. But with the development of the internet, and then the development of smartphones, and then the development of the speed of the internet, and then the ability to digitize medical devices. For example, X-ray machines were all analog, not digital, for more than 50 years. But nowadays, even X-rays, CT scans, MRI machines, all of them are digital. They produce the image in a digital format, not on a plastic film like we used to see them. And then we have to take all these plastic films, heavy ones. We can ship them by mail or send them with someone to the doctors to see. But nowadays, you can share that easily through different applications with the very best quality of resolution. Now, the three distinct types of telehealth or teleservices, we can classify them into synchronous, asynchronous, and remote monitoring. Synchronous refers to the delivery of health information in real time. For example, if I'm conducting a teleconsultation, I need the doctor and the patient to be connected at the same time. This is the synchronous type. Surgery is a synchronous type. But if I don't really need to have the two parties connected at the same time, for example, I can store the image from the radiology and then send it to the doctor, and then overnight the doctor could write the report, could diagnose the condition, and then send the report to the other doctors or to the patients, or to decide if the patient should be admitted or not. Then this is asynchronous, because you don't need to have the patients and the doctors connected at the same time. Now, remote patient monitoring is a very important technology that we have. We already have these monitors integrated into our smartphone apps. Smartwatches can measure the blood pressure, can measure the heart rate, body temperature, can measure the number of steps you are doing, can report your location. Some sensors can report falls inside houses, homes, can report if someone was lost, if someone lost their consciousness, if someone needed help, if heart rate was irregular. All of these could be considered part of patient monitoring remotely. But we noticed that, for example, teleradiology and telepathology are among the most advanced or the highest implemented teleconsultations and telehealth applications because they depend mainly on images and videos. Telecardiology is still developing, dermatology, dentistry, psychiatry, stroke, trauma, wound care, all of these can be done as well, but they will need more time to get the same level of maturity like teleradiology and pathology. So do telehealth services provide equal to or better than direct face-to-face care? This is a question that we need to answer because maybe it's not providing the same quality of personal care, but it could provide a feasible alternative to face-to-face interaction. So if there is no way for the patients to travel to the doctor or for the doctor to travel to their patients, then a telehealth teleconsultation service could be a very feasible and effective alternative. Some research says that it's not better than face-to-face direct personal care, but it's a very good, effective alternative when face-to-face is not possible. Now, we have competencies as well, because we need some skills for the doctors to do it. We still have some confidentiality and privacy concerns because some people would argue that, okay, this information is transmitted, this video is being recorded, this image is being hosted somewhere. So are we guaranteeing the confidentiality and privacy perfectly? And then the scope of clinical practice and so on. So when we look at the BELT framework, standing for bandwidth, education, leadership, and technology, these are the four main key components which are considered for successful implementation of telehealth programs. We need bandwidth to transport rich information like MRI images or videos. We need good training and education of end users as well as patients. We need good, strong leadership, and we need reliable technology as well. However, we still have certain challenges, such as the liability. For example, who is responsible for the outcomes, especially negative outcomes or negative consequences if teleconsultation was done, wrong medication was prescribed, for example, or a problem happened because of this kind of consultation or prescription? Who holds the liability? The next point or the next challenge is the licensure, which means that, okay, in Australia, you need to be registered with APRA as a nurse or as a doctor. But what happens if we have a doctor from overseas? They are located in the UK, they are located in the US. What should we do about their license so that we can allow them to provide teleconsultations to patients inside Australia or the other way around? Now, the next challenge is reimbursement. Do we have a model for good reimbursement that can provide these healthcare professionals with their reimbursement based on these teleconsultations? Until 2007, even in the United States, there was no legislations clearly stating and verifying the reimbursement for teleconsultations. So teleconsultations were only done just like a part of the initial consultations, but they were not reimbursed separately, and no one could claim, until 2007, no one could claim reimbursement for these standalone teleconsultations. The workflow also is very important so that we don't need to use a different system, install a new technology, for example, bringing a different webcam or microphone or very expensive hardware or software and so on. So we need to optimize the workflow into the day-to-day activity of the doctors, as well as the financial and feasibility capabilities of the patients who should be able to receive this kind of telehealth. Again, personal health ecosystem includes, as we can see in the image, showing sensors, showing even weighing scales, blood pressure, glucose monitoring, oximetry, spirometry for lung functions, medication tracking, reminders, fitness, and different connectivity technologies like Bluetooth and Wi-Fi, and then different hardware technologies, including desktops, laptops, iPads, mobile phones, smart apps, smart watches, wearable devices, and so on. So this represents the personal health ecosystem that can support telehealth and teleconsultations. And then we will find many of the organizations responsible for developing these telehealth consultations or telehealth regulations, legislations, standards, clinical guidelines, and so on. For example, the Australian Telehealth Society in Australia, Queensland University, they have a Center for Online Health, the Australian and state health departments, the American Nursing Association, telemedicine associations, and so on. Now we have the last topic today, and it's Vasu.
Thank you, Dr. Muhammad, for providing your insightful information regarding personal health record and telehealth. Let's move with the last topic, that is mobile health. um, as I think everyone may guess the definition, mobile health, or sometime also called as M-Health, it refers to the use of mobile phones and other wireless technologies to deliver and support healthcare services. So the most common mobile tool which we use in mobile health are mobile phones, smartphone, wearable devices, portable diagnostic devices, and SMS systems. These are very powerful tool, can be used for educating individual about preventive care, raising awareness, and encouraging healthcare lifestyle. But mobile health extends far beyond education. It play a vital role in monitoring disease, supporting treatment plan, etc. Moving further, despite its promising potential, the adoption of electronic and mobile health technologies, as Dr. Muhammad said earlier, has been relatively slow. Many doctors cite time constraints while patients worry about the security and privacy of their health data. But when implemented thoroughly and securely, mobile health can offer substantial benefits. Its connectivity and ease of use have the power to improve the quality of care, making health services more accessible and manageable for all. So among the key advantages, we have some dotted point advantages here. Mobile health can improve treatment adherence. It can be more efficient in monitoring the patient, and it could be a move toward paperless system that simplify and enhance health information management. Moving further, talking about mobile health tools, application, and usage. M-Health applications serve both consumers and healthcare professionals by improving access to the information, supporting self-care, enhancing communication, and enabling real-time health monitoring. These tools play a critical role in transforming traditional healthcare into a more personalized, accessible, and proactive system. For example, mobile applications are widely used to support healthy behavior, such as exercise, diet tracking, walk monitoring, smoking cessation, and stress reduction, etc. They can help to educate people and promote healthy lifestyle. They can help in remote monitoring and data collection as well. For example, as Dr. Muhammad said, wearable devices. We have many wearable devices available. So wearable devices and mobile connected sensor can collect health data such as glucose level or heart rate, and it can be further connected with the healthcare professional in the future. They can support early detection of issues, can help to provide timely intervention, and can help to provide remote care delivery. So there are many advantages, I would say, and examples mentioned in this slide. They can help in remote monitoring, can help clinician in decision making or disease symptom management. They can also help to have much more improved and informed as well as better communication, and can be used to provide education and training to both healthcare professionals and patient. Moving further, if we look at this slide, it is just a very simple slide talking about the mobile phones, a basic phone, feature phone, smartphone, and tablet, etc. Now, we may think how these various features available in mobile devices can help in healthcare domain. For example, if we talk about basic phones are like they have limited features. They have limited voice call and have simple calling and SMS messaging facilities. So how they can be utilized in healthcare? They can be used for SMS reminder for medical adherence, or, for example, for appointment scheduling, and to educate educate patient in low resource area where smartphones are not widely available. If we talk about feature phone, their capabilities are they have much more better features than basic phone. They have voice, SMS, basic internet access, and simple apps. They can be used, for example, for interactive voice response system, for symptom reporting, or for health education, and can also be used for the data collection by community health workers. If we talk about smartphone have advanced computing powers, internet access, app stores, high resolutions, etc. They have good camera quality, have sensor attached with them, so they can be used for example, for diet, for fitness, lifestyle management, we can say. They can also be used for teleconsultation. The video can be done nicely, can also be used for clinical decision making. If we talk about tablets, the main feature of tablet is large screen size, so they can be helpful in multitasking, where during the visit, a clinician maybe can take notes or can document the process of caring the medication provided. So that is how various wireless devices, if we just talk only about the mobile phone and tablets, can be used. But we are not limiting health services only through these devices. We have many more than these. Moving further, looking at where were mHealth app by category. I would not heavily focus on this slide, but overall, we can say that the adoption of mHealth technology, if we talk about 2025, it reflects a shift toward more accessible and patient-centered healthcare solution. Moving further, here we have more examples of how we can provide the digital solution or digital health solution, including mobile health system. It can support wide range of health function that go beyond direct patient care. As we have done some of these functions, I think in module 1 or module 2 as well. So technology can help various ways in healthcare. It can help in human resource management, finance management, supply chain management, communication, maintaining the record, making the decision, making much more insightful decision for healthcare industry and for the patient. Moving further and looking at examples of use in a spin, we can see where wearable applications are most commonly worn here, as represented in this diagram, and in the statistics they are most commonly worn with 55% of user preferring location due to convenience and accessibility. So these figures may be a bit older. The data here provided maybe, but we have much more percentage increase here for wearable application. Moving further, talking about what are the challenges, driving force of mobile health or M health. So we can say the driving force could be if we have proper regulation for using these mobile health. At the moment, mobile health can offer many benefit. They also pose potential risk. So one major concern is the lack of regulation. For example, if mentioned in this slide, I would say by 2017 there were around 325K mHealth app available, but only a small number had been approved by FDA. So these apps are often considered low risk, meaning they are unlikely to cause significant harm and are not a regulatory priority. So you may see in the market, in the digital markets, there are many applications available, but they if you talk with the healthcare professional or the care provider saying that this is the data I have collected through my wearable or through my device, then they may not be fully relying on that data. Moving further and understanding more challenges, as mentioned previously, many of these app had undergone rigorous review or approval, which if the apps are not approved, saying that if they are, for example, not approved by FDA, if there is lack of regulation, then the healthcare professional will not be trusting on these apps. Additionally, another challenge could be patient may misinterpret the data which is collected with the help of these app. And the major issue it can bring, mobile health can bring, is about data security and privacy. So privacy and security is another significant issue, as sensitive health information may be at the risk if proper protection are not in place. You may be thinking that, for example, electronic health record, how safe it is. We can say that yes, the patient information is kept safely there, but still we cannot deny but the potential of cyber attack, because every day new algorithms are getting designed and people are trying to attack on the personal data or every domain. So we cannot fully 100% say that yes, all the data kept in mobile apps or in these digital places is fully secure and safe. Moving further, talking about mobile health, hold your breath. We say that many see mHealth as the future of healthcare, but questions remain about where this technology is truly heading and how it will shape the lives of those who depend on it. The answer may be in many ways the future has already arrived. As we can see, wearable devices are the part of our daily life, and virtual doctor visits are more accessible than ever. But we still we say that mobile health is open source, open data, open innovation, but we are not fully 100% sure whether we are opening the door to progress or potentially unleashing unforeseen problem. Moving further, this slide is basically very informative slide. You may like to go through this slide later. This slide is providing a concise overview of leading health organizations along with their key resources and databases that may be helpful for you to expand your understanding about mobile health. For example, it include K for Health, which integrate mobile technology into health program in a low resource setting. It is also talking about 9 principles of digital development, which guide the ethical and effective use of technology, health technology. Then it has also provided the information about some organization databases, and if you are interested looking if you want to look for what are the projects run by different organization, so the link with the website are provided here, which are the mobile health project, for example, approved by World Health Organization. So you may be looking at mHealth registry. The mHealth registry is a strategic efforts to consolidate and coordinate mobile health initiative by encouraging organization and government to register their mobile health project with World Health Organization. So basically, this can help to identify if two organizations are working with the similar kind of mHealth project, so it can help to reduce the overlapping efforts. So I will take a pause here. Finally, we can say that the growth of mobile technology, internet access, and various e-health project has opened the door to something even more transformative, connected, data-driven, and intelligent health care system. But we are not still 100% sure how many challenges and what kind of future challenges we may face with this advancement in technology. With this, I'll finish the topic. Thank you very much for listening.
Thank you very
Happy
much,
to take questions.
Dr. Vasu. Yes, we've got a pile of questions here, and I will encourage everybody to get your questions in. We'll close the questions in about 10 minutes or so just give you a bit of a time. There's a couple of questions from the early ones around the difference between sort of EHR, MHR, PHR. Like, what's the standout sort of differences between all of those?
Well, I can answer this question. The electronic medical records are more about the clinical aspects or clinical sides of the healthcare provision, like diagnosis and treatment, medications and radiology, lab, and so on. When we say electronic health records, this includes, in addition to the medical record, it includes other administrative things, including insurance, including reimbursement, information, payments, including other things that are related to the administrative functions. So it's wider than EMR. When we look at the third was the personal health record, this is a new concept where patients and health consumers, just like us, we can have access and control over our electronic health records. So then we can call it personal electronic health record or electronic personal health record. So it's even wider than the electronic health record. Yeah.
Ray's asking us to address the questions of governance and risk, particularly privacy and personally identifiable information.
Well, this depends on the type of the use of the information. If the information is used for healthcare provision directly, so we cannot really mask the information or de-anonymize or remove the identifiable information because we need that information to provide healthcare. such as the age or the gender or the comorbidities and conditions and so on. But if the information is intended for other secondary purposes like health research and studies and so on, then we can mask the information or remove the identifiable information. This is why it's very important to have good governance in this area of privacy and confidentiality.
Okay. As an e-patient, sometimes your own research is really good if it's done properly. It should never replace advice from clinical specialists, though. How can that be assured? How do you manage that process?
Yeah, I think when we are saying that we are collecting information and we think that is much more better than what clinician is saying, in that case I would advise it is good to always check with healthcare professional because they have studied in that area. It may be they may have missed the point or they may be still looking at your health condition and observing the symptom. But if you find some information, it is always good to check with your clinician. It is always good to check with your GP. Hey, this is the information I have found. What is your advice and what are your comments? So finally, yeah, you have to go with your clinician advice.
Aha. Are we in Health 2.0 or 3.0? And what's the difference?
We are in health, we are heading in health 3.0. So basically, the concept of health 3.0 comes from Web 3.0. Initially, when we started with websites, so how the website used to be, they used to be static website where we can just read the information. They were not interactive. But nowadays, if we see the some websites are more interactive. For example, we can fill the form, we can get some response. We have chatbot attached with the website. So Health 3.0 concept come from Web 3.0. So if we try to understand the concept of Health 3.0, we can say Health 3.0 is much more, I would say, intelligent, much more smarter, much more connected with the patient. Is the same concept I can repeat in Health 2.0. In Health 2.0, we say we have access only where we can read the articles. Whereas in Health 3.0 is the concept where, for example, we have wearable, we have Apple Watch, we have health tracker. So they can let us know whether for how long I was sitting in front of my computer. It's time to get ready, mindful applications there, sleeping application there, exercising application. So that is the concept of Health 3.0.
Okay, so Noah's question is about the data accuracy of wearable smart devices. Has there been any research done in comparing that sort of data from wearables and consumer devices and the sort of dedicated devices that have been around for years?
There is lot of result in mobile health area. They talk about the feature, they talk about how they are providing the support. And yeah, if you look at the literature, for example, PubMed, you may be able to find many published article there which will be talking about mobile health, comparative study, comparison between various applications.
Great. A couple of questions about the safety and governance around PHRs. If the data is actually out with people's own computers, how do we protect them from hacking and then getting into the system? And is governance overall in place to try and protect those things happening?
Yeah, definitely. End users, they have access to this personal health record through accounts like usernames and passwords and security checks and two-factor authentication, like sending a message on your mobile phone so that you can receive a code and then use the code to access your information. So it's not easily hacked by external users or unauthorized users. However, we still have the general perception among among the public that these are not secured enough because they are on the cloud or they are shared with different providers and different hospitals. So we need a balance between the actual confidentiality and security of this type of information and the level of awareness of how confident we can be for using this kind of information.
Is there, as a follow-up to that, which I think is actually really pertinent, is there some sort of grading mechanism between the data received from different sources so that data from, hospital machines is perceived at a higher level than data from your smartwatch?
Definitely, we still have a lot of validation to be done for these wearable devices. For example, we know that sphygmomanometers, which measure the blood pressure in hospitals, are more accurate than those sold in the pharmacy that you can use at home. But again, those which are used at home, we don't use them to prescribe medications. So if someone got his blood pressure measured at home, and then found that he has a hypertension, increased blood pressure, it doesn't mean that automatically he can take a drug to reduce his blood pressure. But this is like a monitoring. It's like an index test. It's not the gold standard. So the gold standard is still the devices that are validated for healthcare provision at hospitals. Those that we use as smartwatches, smartphone apps, devices that are sold for people to use at home, we consider these as index test, as monitoring, as scanning, as survey. Then if I know that my blood pressure could be high, then I need to go to the doctor. So because we have so many validation that has to be done in terms of sensitivity and specificity and performance of these devices, so we use them generally as a scanning tool, as a monitoring tool, not as a diagnostic tool, just like we use the rapid antigen COVID test compared to the PCR COVID test done at the hospital.
I know exactly what you mean. I have a literally $20 Aldi heart blood pressure monitor. And to be honest, it seems to work as well as the one at the doctor's surgery, but I'm sure it's not as good. But honestly, for $20, that's all I
Yeah.
care about.
Yeah.
Would you say that the healthcare industry as a whole is ready for some sort of disruption, a democratization of health management away from medical specialists, or, maybe something like the Theranos thing, but that actually worked?
Well, I don't believe that the healthcare industry is very ready and prepared for this kind of disruption and change. I think it's going to take some time for healthcare professionals to realize that software and AI can replace some of the jobs that they do, can replace some of the functions that they do, and then what other functions they need to, or skills they need to acquire to be able to cope with these changes. For example, maybe you have heard Bill Gates a few days ago mentioned that doctors and teachers could be very soon replaced or partially replaced by AI, which doesn't mean that uh, AI can completely replace the doctor functions, but can replace some of their tasks that they do, like writing the final report, preparing the group of symptoms and signs in one context, or providing differential diagnosis, list of short-listed diagnosis, or, for example, prescribing a specific type of lab tests to distinguish between two possible medical conditions, and so on. So we need to learn, as doctors and nurses and healthcare professionals, we need to learn new skills to be able to drive and control and work with these new technologies.
Thinking of the right question to ask at this point. Will M Health apps get to be considered medical devices at some point? Do you think they'll go through some sort of registration process, maybe?
Maybe Vasu can answer this.
Yeah, they the in the M Health devices we have even we have our personal mobile phones as well. But if any application or any device is not approved, for example, by FDA or any reputed organization, then the data collected through that device will not be somewhere considered as fully 100% trustworthy. It may be helping clinician just to make the basic understanding about the patient health condition, but it will not be fully if they are not approved devices or approved application, then we cannot 100% trust on them.
As a bit of a follow-up to that, while all of these apps are growing, you can do initial diagnosis, of course, but for getting the scripts, etc., you really need to go to a doctor still, of course. Do you see a
Yes,
future where the apps will be able to do basic prescriptions?
yes, yeah. Yeah, that's what we can say, that it may help in basic screening, but we cannot say that it will be fully replacing the job of healthcare professionals.
No, of course not. I guess it would be interesting to see if that happens, if we'll be able to get some of those things over the counter, considering that they all appear to have been roped in over the last few years from where it was a few years before that. Um, while technology can help make the right decisions for patients and clinicians, it also has a drawback in that it can cause anxiety for the patients. Have this been around long enough to research this aspect?
Yeah, we have studies mentioning the drawbacks and disadvantages and over reliance on technology. For example, when we implemented electronic health records across hospitals, then the generations, different generations of doctors and nurses started using this for maybe 2 or 3 decades now, more than 30 years. And then if the system is down, nobody knows anything about the paperwork, the paper records. How can they prescribe medications inside the hospital on a paper, because they don't have that anymore? This is over reliance. Another form of over reliance is, for example, when we are used to receive drug to drug interactions generated by these systems, and then all of a sudden the engine stops for any reason. Then simply the simplest form of drug to drug interactions can be missed, because the doctors are used to receive these alerts. If they receive no alerts, then they think that they are safe. Another drawback, for example, is the alert fatigue. When we have too many alerts generated, and then doctors and nurses start just clicking OK, OK, or next, next, or ignore, ignore. And then they stop reading the details of these alerts unless these alerts are sorted into critical, intermediate, or minor, or something like that. Then they can, for example, can be highlighted by colors red or yellow or green or blue, whatever, to reflect how serious this is or how threatening this is. So these are all drawbacks that we haven't researched enough, but we have seen in the real life that when these things happen, nobody is prepared to take over again. Once people are used to use technology, they can't really go back to the old fashioned. Now, who drives a manual car, for example, nowadays? Almost no one, right? So
Uh,
yeah, this is
yeah.
right.
Yeah, that's right, Muhammad. I would probably like to add here, then we may be looking for more advancement in technology. For
Yes.
example, blockchain technology, where we may have data stored in all over the different places. So if something going wrong with one server, the data can be fetched from another one, etc., etc.
Very interesting. And I know a couple of people that would be outraged to think that you shouldn't be driving a manual car these days as well. When we say consumer entered information, do you mean that patients have access to edit the information on the records, or do they just have some sort of portal to stick it in and they can't get back the other way?
Not to edit, but they can copy, they can send, they can share, they can edit a copy, but they can't edit the original record, of course.
Ginny's asking, what are your suggestions for someone who aspires to take a career leap into e-health? This sounds like a Vasu question.
Yeah.
Uh, Career, there are many career opportunities. If you are aligned toward technology, then you may be looking at a career as a data administrator, as a software engineer in health domain, or as a data analyst, as a business analyst from IT perspective. If you are looking from health perspective, then if you are a nurse, maybe looking for the career health informatic nurse, so you may have to have bit of idea about how technology operate, or maybe working as a project manager, as a manager, where you will be taking the overall role of leading the technology, implementing, adopting, educating people. So uh, yeah, it can be done various ways. Maybe Dr. Muhammad may also like to add more information here.
Uh,
Yeah. Sorry again.
Yeah, if I say from IT perspective, um, we have IT help desk, we have
Yeah.
database administrator, we have software engineer, we have cybersecurity engineer, or if we think from somebody coming with medical domain. Then we may have chief information officer, we may have digital health officer, we may have a manager of health projects, so maybe they are overall looking at how various technologies, or maybe helping in the pilot testing of the technology in the health domain. So we have career in health domain from both perspective. We may have career if somebody coming with medical education, for example, if someone is a nurse or a GP or a practitioner, and if they don't want to go, or if they want to balance their work with bit of providing those health services, and bit of want to take management and leadership role, then through this course, or through this kind of knowledge, they can, I think, go in the management side of the role. But if someone sitting here coming from IT background, then they can take more IT specific roles. So they may be analyzing the health data, they may be looking after overall health data, they may be designing the health data, or they may be securing the health data, they may be doing a networking part, protecting the data. So yeah, many careers.
I completely agree with Vazu, and I can give a specific example here. For example, if we have a system that is being developed, then you will find that IT professionals are working in the area of development and coding and software production, while healthcare professionals in the same company or provider, they could support requirements analysis, end user preferences, they could support system analysis, processes analysis, analyzing processes and workflows. They could also support implementation of systems by training the doctors and the nurses on these systems. While the IT professionals, if they are pure IT, they can do the coding and software development. So the industry itself, the health IT industry, can include both sides, just as Vasu mentioned. Yeah.
Yeah,
okay, we're oh,
yeah, yeah. If somebody's personal interest is like me, both in IT and in medical side, but I'm not like a kind of who would be doing surgery. So yeah, they can proceed as an academic as well. I forgot I did not mention my profession. So yeah, they can do the teaching part as well.
okay. We're down to the last minute or so, so we've really only got one question, I think, left. There's about 4 or 5 left here, and unfortunately, we won't be able to answer them all today. So, there's a really good piece of information from Eduardo, which I would ask him to post in the forums. I was trying to post in the chat, and it just does not paste there. So I'm hoping that he can do it. And we will release the chat and the question, so you might be able to see it in that when you come back. But I would make 2 more reminders before I do the last question. They are, remember, please, to fill in the survey. We really do depend upon that in what we're planning in the future. Thank you, John. It's like you read my mind. And also, keep an eye out on your mailbox if you're on one of our mailing lists, because we will be sending out invitations to Mohammed's AI webinar for the 21st of May. They will go out in the next week or so, and there will be reminders as well. It's going to be a fantastic talk. So I'd really, really encourage everybody to come along to that for AI and healthcare. But just to wrap it all up, and it's sort of a bit of a segue from what you're saying before, because one of the ways I think that there's a huge opportunity for people in coming into the course or coming into the area of e-health is through cybersecurity. And I've had a couple of questions. In fact, we've had quite a few questions about things like how you manage regulations like HIPAA and GDPR. How do you then also balance that with the right for somebody to get their own data back? All of that sort of stuff. Do you have anything to sort of comment about that?
Yeah, actually, these regulations are government supported, and they have to be endorsed not just by the government agencies, but also by the healthcare provider organizations like hospitals and within the practice itself. So to make these active implementation, they need to be adopted in a more kind of like a framework that govern the data, how the data is transported, what are the procedures to get the data. For example, if I'm a researcher and I am applying to get some of the data exported from the server of the hospital to my own computer, or to do statistics or to do analysis of data or something like that. So how this data is transferred, what metrics can be used, what guarantees can be in place to make sure data is not identifiable, personal information is not exported, no information in the reports or the history of the patient can be used to identify those patients again, and so on. So this needs not just regulations and legislations, but also needs technical support and frameworks that can support this kind of data sharing and exchange. So it's both administrative and technical as well.
Fantastic. I really, I think at this time would like to say good night and thank you so much to our two presenters, Dr. Mohammed Khalifa and Dr. Basu Sood. I have said off camera a couple of times that they really are presenting a wealth of information, and this is the value of this course is surprisingly high for something that we're providing for free. I just feel like sometimes we have to say that stuff. This really is a postgraduate level course, and some of the information you're getting you won't be able to find very easily at other places, irrespective of whether it's actually in our degrees or not, and in this case it is. So I would really encourage everybody to download the video, have a look at it, log into learn.itmasters.edu.au and have another look at the slides and stuff as well. But please join me in saying thanks, very special thanks tonight to John for being our man on the spot on the chat, and Kit for being the backup everywhere, and especially for Mohammed and Vasu. Thank you, everybody.
Thank you very much.
Good
Thanks.
night.
Good.